So I think we can start. So we look at bone infections and bone tumors. Okay, so we look at osteomyelitis. Osteomyelitis refers to inflammation of bone that is almost always due to an infection. Typically, it's caused by bacterial infection, what we call pyogenic osteomyelitis. It might be acute or chronic. Other non-pyogenic causes of osteomyelitis are what cause chronic osteomyelitis, that is TB, syphilis, and fungal osteomyelitis. Okay. Osteomyelitis can occur at any age. So if we are given the entire population with no risk factors, anybody can get osteomyelitis. In those without specific risk factors, it is commonly between the ages of 2 to 12 years of age, so the pediatric population. Unfortunately, like many other diseases, it is more common in males. So generally, I would say that other than the hormonal disorders, most of these other diseases are more common in the males. So the hormonal disorders, I'm talking of thyroid, parathyroid, those ones would be more common in the females. So it has a ratio of 3 to 1. Pathology, it spreads by either by hematogenous spread. So this is whereby a patient is septic, has septicemia from whatever other source, and then it is inoculated into the bone. You can have direct implantation, e.g. a patient who's had a panga cut. So the panga was dirty, had some germs on it. So you can directly inoculate into the bone. It can also be iatrogenic sources. So for example, a patient who is getting a knee transplant. So if that implant was not well sterilized, it can be a source of bone infection. Then you can have an extension from adjacent soft tissues. This happens especially in patients who have diabetes. So they get a diabetic foot, they get an ulcer, and that ulcer slowly gets into the bone. Then what are the organisms? With or without any predisposing factors, the commonest cause of osteomyelitis is Staph aureus, okay? Whether the patient is a sickler, whether it's a diabetic, whether it's an alcoholic, the commonest organism is Staph aureus. Over and above Staph aureus, these different groups of people will have these other organisms. So in the newborns, you'll have group B, Streptococcus, E. coli, and H. influenza. In children, it's almost purely Staph aureus. In adults, you'll have the enteric species and Streptococcus being added. In the drug addicts, they tend to get over and above the Staph aureus, they tend to get Pseudomonas and Klebsiella. And in the sicklers, they tend to get Salmonella typhi. Okay. The location, I like looking at it in terms of a descending order. So it's commonly seen in the lower limbs, and in the lower limbs, it's more common in the tibia than in the femur. So you commonly see it in the tibia, then followed by the femur. Then in the vertebra, it's more common in the lumbar, followed by thoracic, and finally in the cervical region. Then other sites include the radial styloid and the sacroiliac joint. So what do we see when we do imaging for acute osteomyelitis? So for the first 7 to 10 days, you may see nothing. So you will have a patient, a mother brings in a child, tells you, my child has not been able to step with his leg. So the doctor suspects, you are the clinician seeing the patient, you suspect, well, the child is having a fever, the limb is painful to touch, they are not using it, then you send them for an X-ray and the radiologist reports a normal tibiofibular X-ray, for example. That does not rule out osteomyelitis. It will be normal within the first 7 to 10 days. Thereafter, you start seeing soft tissue swelling. So when you have soft tissue swelling, you lose the normal tissue planes. Okay. Then you will also have osteopenia. So remember, osteomyelitis, just like any other inflammation. Do you remember the inflammation we studied in year 3? So you are having increased blood supply to the site. You are having increased temperature in that place. And this is because we are recruiting the monocytes, the basophils. We are recruiting all those cells to that site. So, and for bone specifically, we'll be having the osteoclasts. So there will be, the osteoclasts will be taking away the bone and making it osteopenic. This is not normally visible until week 2 to 3 after the symptoms have started. We have the early periosteal reaction as well. This is whereby the bone is reacting to the inflammation. So there is a periosteal reaction of bone. I'll be able to show you that in a short while. The other imaging modality and that we commonly use in children is ultrasound. So this is to assess any soft tissue edema. We will assess subperiosteal collection, so they might have abscesses collecting. You can also have soft tissue abscesses, and that can extend into the joint. You can have a joint effusion or even pus in the joint or pus in the muscles. Other imaging modalities that can be used, we have skeletal cintigraphy, whereby we use technetium-99 that is labeled with diphosphonate. Diphosphonate is bone specific, so the technetium-99 is labeled with diphosphonate, and that will collect in the site that has an infection. So unfortunately for scintigraphy, it's not specific. It's very sensitive. It will pick anything. If you have a fracture, if you have an infarct, if you have a tumor, you will have that site picking up the radiopharmaceutical. However, once you see that site, you describe it as an increased uptake or a hotspot. It doesn't necessarily mean it's an infection. So it can be anything else. It can be a fracture, it can be an infarct, it can be a tumor. So it's very non-specific, but it is very, very sensitive. The other flip side about it is that it's ionizing radiation. I hope we all remember what ionizing radiation was. Ionizing radiation is whereby you are having the energy that is being produced is able to remove an outer electron. You remember the atom in first year when we did physics and we had the inner shell with neutrons and protons, and then you have the electrons on the outer shell. So if the energy, for example, the X-rays have energy enough to remove an electron from the outer shell of an atom, so that makes it an ionizing radiation. Same for scintigraphy. It has enough energy to remove an electron from the outer shell of an atom, so it's an ionizing radiation. What does that mean? It means it's not safe. Okay, so by the time you decide to order for a skeletal scintigraphy, then your benefits should outweigh the risk, because the risk, as you can see, is already high. Okay, CT scan, it's very good. It gives us specific anatomical information. It tells us the status of the infection. How far is it? Is it involving the bone only? Is it involving the adjacent soft tissues? It will show us intraosseous gas. We'll see subperiosteal abscesses. We'll be able to pick any edema if it's there. And unfortunately, again, it's ionizing radiation. So it is not that safe. So you have to weigh your benefits versus the risk. And then there is MRI. So MRI is very good for soft tissue assessment, very good for picking the pathology, but it is costly and also it takes time. I'm sure for those of you who already rotated through MRI, you've seen how long it takes to acquire one image. It takes between 30 to 45 minutes. So if you're having a patient like a child, you would need to sedate that child. If you're having an unstable patient, confused patient, they will not be able to tolerate the examination, because you need the patient to be still for the entire procedure. And if they move halfway the procedure, then you have to repeat that sequence which the patient moved. So, but what do we see when we do the imaging? We'll be able to see any fluid collections, whether within the bone, whether in the subperiosteal space or in the soft tissues. We'll be able to pick any edema, any exudates within the medullary space or in the muscle, the myositis. The benefits is it has no ionizing radiation and it is very sensitive and specific. You remember with the skeletal scintigraphy, which we said it was very non-specific. So MRI is sensitive as well as specific. And as I have said, it's costly and takes time. Okay, so that was my I was trying to put management, antibiotic use, but I'm sure you guys are far much better than me in this because you see those patients in the ward. So I will not go through the treatment. Sorry. So we will proceed to the chronic osteomyelitis. I think I will zoom. Yeah. So chronic osteomyelitis, the causes. So I think at this point, I want to make a delineation. What is acute and what is chronic? So acute osteomyelitis is normally anything that the symptoms have been there for 0 to 14 days. Then we have 14 to 30 days. Normally we call it subacute osteomyelitis, but rarely do we define it radiologically because the signs are intermediate. So radiologically, we'll talk of two things, acute or chronic osteomyelitis. Chronic osteomyelitis will have been there for more than a month. So the cause of chronic osteomyelitis is a poorly treated acute osteomyelitis. The mode of spread will still be the same. So the patient either had a hematogenous spread from septicemia, trauma from compound fractures, for example, iatrogenic causes, whether we are having the extophyx or we are having internal replacements like a joint replacement. Then there are other infections that more or less will always give you a chronic osteomyelitis. This is TB, syphilis, and fungal infections. Reason being, the TB will give you no acute features. So by the time the patient is presenting, they've already had the infection there. It has already settled in, it has damaged the tissues, and you're having the chronic phase of disease. So that is the time the patient presents. So TB, syphilis, and fungal infections, they tend to present as chronic osteomyelitis. Then, as I said, you can also have contiguous spread from soft tissues, especially among the diabetics, and also patients with peripheral vascular diseases. Imaging findings when we do the X-ray. So I combine the X-ray and CT because we see more or less the same features. So you will find local osteopenia, so there's bone loss, because osteoclasts are being recruited to the site, but there's also recruitment of osteoblasts. So osteoblasts are trying to lay new bone, okay? So because of that, you will have formation of what we call involucrum. Involucrum is the new bone that is being laid by the body. The body is trying to heal itself. So there's osteoclasts taking away bone, giving you osteopenia, and osteoblasts laying new bone, giving you involucrum. Then you will also get now what we call the aging periosteal reaction and Codeman's triangle. This Codeman's triangle, I'll show you an image in a short while, will make osteomyelitis be a differential of osteogenic sarcoma because both can have Codeman's triangle. You can also get focal bone lysis, and we have the sequestrum. Sequestrum is the dead. Okay, so the body, remember we've said there's recruitment of the monocytes, basophils, the body is trying to heal itself, macrophages. So there's that destruction and as well as new bone being formed. So the dead bone will be sequestrum, the new bone will be involucrum. Then there's formation of the cloaca and the sinuses. So whatever the body is trying to discharge will go out through a sinus, and then the cloaca will be formation of the bone defects. Okay, on CT we continued, we'll also have endosteal scalloping. So you can imagine the bone is a compact compartment. So when there's increased pressure because of infection, that pressure will be applied on the inner margins, the inner cortex. So that will give a scalloping impression on the bone. So that's what we call endosteal scalloping. Then you can have loss of bone trabeculi. I'll show you what bone trabeculi is. Then you have new bone that is just misplaced, not in the right place. So you have new bone apposition and heterotopic new bone formation. Then you eventually get peripheral sclerosis, and possibility of getting fractures because the bone has been weakened is also high. Okay, so this is an image that the patient had, both skin sclerosis. You can see the skin is taut pulled in, so sclerosed, as well as there's a discharging wound at that site. There are actually two wounds that are discharging. So those are the discharging sinuses. If we look at this image, so if you look at the center of this bone, there's white bone. That is not a normal location for the dense bone. Normally the dense bone is the cortex on the outer margin. So this is sequestrum, the dead bone. Then here at the margin, you can see a thin layer of bone that is not as dense as the inner margin. This is the involucrum. If you look down below here, you can see things that look like lines within the bone. This is the trabecula. Remember the bone trabeculations. So this is the trabeculae of bone. But now when you have osteomyelitis, that disappears. You can see at this point, we can't appreciate the trabecula. You can appreciate part of it here, but there isn't so much trabeculation at this point. There is a small cloaca here. I'll show you another cloaca in the next image. Okay. So when the surgeons go in, this is what they see, the dead white bone, the sequestrum. And then there is this purplish involucrum, the new bone. Okay, so they remove the sequestrum and they leave the involucrum. Okay, so this is the cloaca. So you can see the trabeculae at this point. This bone still has trabeculae here, but this is a cloaca on the bone. This is MRI. So you can see the beauty of MRI. So from this image, you can tell the extent of the infection. So you can tell that for sure this infection does not extend into the diaphysis of this femur. This is where it ends. Okay, so that's the beauty of MRI. You are able to categorically state how far the infection has gone. You are able to assess the soft tissues. Okay, so you can see the fluid within muscle. You can see the fluid within the joint space. Okay, you can see this fluid here in this is the patella. So this is in the suprapatellar space. So you can see that fluid there. And the other good thing about MRI is assessment of ligaments. This is not for osteomyelitis now, but just generally as MRI in MSK imaging. You can see this ligament very nicely, okay? The suprapatellar and the infrapatellar ligament. And behind here, we can see part of the posterior cruciate ligament. Okay, so it's very good in assessment of ligaments, and especially in sportsmen or any other person when they get ligamental injuries. We are talking of the menisci, we are talking of collateral ligaments, medial lateral collateral ligaments. We are talking of rotator cuff injuries in the shoulder. So it's very good for assessing those ligaments. And of course, in the spine, we also assess the ligaments as well. So MRI is very good for ligamental assessment, soft tissue assessment, and even bone lesions. You can assess the medulla. Okay, and maybe I'll mention that a little bit later. The other imaging modality I said was ultrasound. So like this circumflex artery normally sits right at the cortex, but you can see there's elevation because there's some fluid within this soft tissue. Okay, so this is CT. So these are reconstructed images, so we can appreciate you can see the bone changes. So there's the bone sclerosis, there's destruction of bone, so there's missing bone in there. Okay, you can see the irregularity in the cortex here, and you can see the sclerosis at this point. Any questions this far? Okay, I can see someone was asking, was sequestrum the black or the white region? So sequestrum is the white region. It's the dead bone. So I'll go back there. Oh, sorry, I'm going up. Yeah, so let me just zoom in a little bit. Okay, we can see the white, like a line of bone in here. That is the dead bone. It's the white here. Okay. So that's the question. Any other question? Okay, so there are no questions. That is my question to you. Where is this place? Anybody? Somebody? Oden? Kevin?
Yes, doc.
Where is this? This image I'm showing you, where is that?
I'm not sure, Dr. where that is. I've never seen it.
You've never seen it. Anybody who
Yeah.
has ever seen it? Anybody who has ever seen it? The rest of the class? Let's see, someone is. Nice try, but this is not Brackenhurst. Brackenhurst is in Limuru. This is in the Rift Valley in Wazingishu, to be specific. Is it Wazingishu? Is it KU? That's in North Rift. I think it's in KU. So this is Samich, the famous Samich. So I encourage you guys to make a few trips over the weekend when you're not busy reading. I don't know, but when I was in med school, 5th year was the best year because there wasn't so much pressure compared to 4th year and 6th year. So at least you could have a few free weekends here and there to visit the city. You know, the next time you may be posted to Kilifi and you get a wife in Kilifi, then you may never come back to the North Rift. So it is good to travel. Too much, what makes, is it Jack or Tom a dull boy? Okay, so bone tumors.
Jack who's
okay.
Yes.
Okay, so let's not be the boring Jack. Let's not be dull. So, of course, you also need to read. Okay, bone tumors. So I will look at a few benign tumors and a few malignant lesions. Okay. So let's start with bone infarcts. So bone infarcts, we are commonly seeing them nowadays than before, especially in our setup, because now we are doing, sorry for that. Okay, so we are seeing bone infarcts now more commonly because we are doing a lot of renal transplants, and we are doing, there are malignancies that we are managing, that we are putting our patients on high dose steroids. For example, multiple myeloma. Sometimes we put these patients on very high doses of steroid that causes them to get bone infarcts. So typically they present as central lesions in the metaphyses or diaphyses with a well-defined serpiginous border. They may resemble cartilaginous tumors. So maybe at this point I need to put a caveat. Tomorrow when you'll be practicing as an MO out there, when you see a bone lesion, even for the radiologists, bone lesions are hard. So normally I'd say when you see a bone lesion, just refer it to the right people. Send it to an orthopedic surgeon, let the image be read for you by a radiologist, okay? Because they're not easy lesions. A benign lesion can look like a malignant lesion. So, and you don't want to biopsy a patient who has a bone infarct, for example. So they may resemble cartilaginous tumors. Causes, as I've said, corticosteroids. You can have sickles getting bone infarcts because of the bone crisis. You remember what happens in sickles? The cells are deformed, the blood vessels get clogged up, and they end up cutting off supply to that part of bone, and they get a bone infarct. Then trauma, and the sites that we commonly get trauma, you remember the blood supply to the femoral head. You remember the blood supply through the neck of the femur. So if this patient gets a fracture neck or femur there, they may get a femoral head bone infarct. The other site is in the scaphoid. A majority of people have the blood supply to the scaphoid coming from the distal aspect of the scaphoid. So if they fall on their hand, get a fracture through the body of the scaphoid in the hand, then the proximal aspect of that scaphoid will be avascular. So it will get the bone infarct, or what we call a vascular necrosis. Other causes include Gaucher's disease. And in an exam, if I ask you and you tell me Gaucher's disease, my next automatic question will be, okay, someone says they can't see the presentation. Are you able to see the presentation? Kyoko?
Yeah, I can see it.
Okay. I don't know. Someone says they're not able to see the presentation. I don't know what's happening. Probably internet on your end. I don't know. So I was saying that when you tell me Gaucher's disease as a cause of bone infarcts, my next automatic question is, what is Gaucher's disease? So you better be knowing what Gaucher's disease by the time you give me that answer. Then the other cause is in renal transplant patients. So how do they look like on X-rays? You can see this is an MRI. So you can see what we call a serpiginous lesion, snake-like, okay? So if I see this X-ray, I will just tell you this is a bone infarct. Don't do anything about it, okay? Unless the patient gets a fracture, then there's no need for you to do anything else. And chondromas, these are well-defined osteolytic cartilage-forming lesions, most commonly seen in the hands. And the history is normally my finger has been growing larger and larger. So probably they're presenting just because they are concerned. They've had a finger that has been enlarging for the last several years, or they have gotten pain suddenly, which they've not been having. So the common locations are femur, humerus, and the metacarpals. They must have calcifications, but not in the phalanges. Okay, so how do they look like? So this is a nice classical one, okay? You can see this expansile lesion in the finger. So because of that expansion, they tend to break the cortex and they present with pain. So like in this patient, you can see there's a breakthrough. So with that fracture, they will present with pain, but the patient will tell you this finger has been swollen for the last 3 years. So it's a slow growing lesion, okay? ABCs, aneurysmal bone cyst, typically present as a painful expansile lesion, well-defined osteolytic lesion in young patients that's less than 30 years old. We see them on plain radiographs as a ballooning lesion. And normally we have what we call a characteristic appearance, both on MRI and even on plain X-rays. So on MRI, we have what we call fluid levels. That is because within the aneurysmal bone cyst, there'll be blood products. So the blood will be disintegrating, and you'll have different, there's the hematocrit, there's the more fluid, the more dense, so you'll have the fluid levels, okay? Then on an X-ray, you may find what we call the fallen fragment sign, okay? So because it's a ballooning lesion, then it breaks, the cortex breaks, but because there is fluid within the cyst, that bone fragment falls into the fluid and will sit at the base of the fluid, forming what we call the fallen fragment sign. Okay, so this is how it looks like. So this ballooning lesion, and then it will have this, I think this MRI is the best to see the fluid levels. You can see that. This as well, you can see there is a slightly, this is more ISO, this is slightly hypo intense compared to when you compare the two, and that is a normal medulla. Okay, Ewing sarcoma. So now I'll look at the malignant bone tumors. So I'll look at two malignant bone tumors, that is osteogenic sarcoma and Ewing sarcoma. So Ewing sarcoma is the second most commonly highly malignant bone tumor in children, fall after osteosarcoma or osteogenic sarcoma. But when you rank all the tumors, grown-ups and children, then you'll have multiple myeloma being the first one, then osteogenic sarcoma being number 2. Ewing sarcoma typically arises from the medullary cavity with the invasion of the Hervetian system. You remember the Hervetian system, the blood supply within bone at the medulla of bone, so it invades the Hervetian system. Usually presents as a moth-eaten, destructive, permeative lesion in the shaft of long bones with large soft tissue component without osteoid matrix. What do we mean? There is no bone deposit within the soft tissue. So that is a differentiating factor between Ewing sarcoma and osteogenic sarcoma. Both of them will have a soft tissue component, but osteogenic sarcoma will not have bone within it. Whereas, Ewing sarcoma will not have bone within it, whereas osteogenic sarcoma will have bone within the soft tissue component. The other thing that makes Ewing sarcoma differential of osteogenic sarcoma is onion skin periosteal reaction. So you know the purple skin, right? The purple onion, what we call red onion. Okay, you can see this layering here. This is what we call an onion skin periosteal reaction. And this is how it looks like. You can see layers of bone. So this is the normal cortex here, but you can see layering of bone here. So this is, and also part of it here, you can see it on CT here. So this is the layering, the onion peel appearance of Ewing sarcoma. Okay, typical, it may also involve flat bones and appears sclerotic in up to 30% of patients. So this was a patient we had in MTRH, had a metastatic lung lesion. When they was treated with chemo, this thing just disappeared. The next chest X-ray was normal, but you will look at the lesions. This is a periosteal reaction here. This one is a lesion here with periosteal reaction. So you look at it when you get the images, there are more lesions down here. So they're destructive lesions. Okay, so osteogenic sarcoma, this is a malignant bone-forming tumor, second most common primary bone tumor after multiple myeloma. It accounts for about 20% of all primary bone tumors. So it is the commonest bone tumor you'll see in the younger generation. Okay, and what is that age bracket? We normally say 10 to 20 years, but you can see it up to 25 years. So we have two types of osteogenic sarcoma. Primary osteogenic sarcoma that we see in the young patients, that's the 10 to 20 or to 25 years age bracket, with 75% occurring before the age of 20. Why? Because the growth centers of the bone are more active during puberty and adolescence. So it also has a slight male predominance. Secondary osteogenic sarcoma occurs secondary to another bone lesion that was there. So either the patient had Paget's disease, had extensive bone infects, patient has had radiotherapy for whatever reason, either Hodgkin's lymphoma, for example, they've had osteochondroma or osteoblastoma. Clinical features, patients usually present with bone pain, occasionally accompanied by a soft tissue mass or swelling. Okay, at times the first symptom is a pathological fracture. Normally, there will be a history of trauma, which is a red herring, which is not true history in the sense that the mother will tell you, mtoto wangu alikuwa anacheza football, akaanguka, and now here we are. So you do an X-ray and you see an aggressive lesion that does not look like it is trauma related. Okay. How does it look like on plain X-ray? So there's medullary and cortical bone destruction. Forget about this thing called wide zone of transition. We'll discuss it when you come for your MED, but there's permeative or moth-eaten appearance. There is aggressive periosteal reaction. What do we mean by this? We mean sunburst type of bone reaction. Okay, then again, there is Codeman's triangle. Remember, we saw Codeman's triangle in osteomyelitis. I think I will put an image in this presentation at some point before I share it with you guys of Codeman's triangle, how it looks like. So that makes osteogenic sarcoma differential of osteomyelitis. Then we have the lamellated or the onion skin reaction, making osteogenic sarcoma a differential of Ewing sarcoma. Soft tissue mass seen both in osteogenic sarcoma and Ewing's, but Ewing sarcoma has no bone matrix within the soft tissue. Then we said tumor matrix ossification, that's bone within the soft tissue mass. How do we scan these patients? So you've done the X-ray, you've seen what you've seen, then we do staging using CT and MRI. MRI is you want to assess for any skip lesion. So the patient has, for example, a distal tibial lesion. So that patient may be having skip lesions probably to the proximal aspect. Let's say they had it at the knee area. Then they have another lesion at the femur proximally. So you will be able to pick it with CT or MRI. So they're good for staging. Then the other place osteogenic sarcoma metastasizes to is to the lungs. We get cannonballs in the lungs. So we want to do a chest CT scan to rule out any lung metastasis before we start treatment. So this is a distal femur osteogenic sarcoma. You can see a soft tissue mass here. You can see the calcification within the soft tissue. You can see the destruction within this bone. Okay, so nowadays we have what we call limb sparing surgery. So if we stage the tumor and we say there is no other bone lesion in the same bone, then we can just amputate that part of the limb that has tumor and leave the rest of the bone. That is an MRI of the same patient with the distal femur osteogenic sarcoma. Okay, here is the Codeman's triangle. You can see this elevation. Okay, so this is the Codeman's triangle. We see it both in osteogenic sarcoma and chronic osteomyelitis. I have a list of metastases for lytic and osteoblastic lesions. So you will go through it at your own time. But of note is that in the lytic lesions, you will have thyroid, you will have Wilms tumors that you will commonly see, you will have melanoma, squamous cells, cell carcinoma of the skin will give you lytic lesions. Then osteoblastic, the commonest we see in our setup is prostate carcinoma. It will give you bone forming, or what we call bone sclerosis or osteoblastic metastasis. Breast carcinoma has a mixed picture, both sclerosis and lytic lesions. The question I hear commonly is, does lymphoma give us bone metastasis? The answer is yes. And when it does, it will give you bone sclerosis. Any questions? Before we are logged out by the system? Any questions, guys? Are you okay?
Yes, Dr. Asante.
Okay, you can unmute and ask any question if you have